Welcome back to Pediatric Medical Disorders, Part 3. The final disorder we're going to discuss is growth hormone deficiency. This deficiency can be due to inadequate secretion or production of growth hormone. It can be an issue in and of itself, or it can be associated with bigger problems. Panhypopituitarism, a brain tumor, a history of having radiation to the head, or it can be a hypothalamic problem. The clinical manifestations are that this child does not grow in height. They put on weight, but they don't get taller. So what we'll find is that the height is in the less than 5th percentile for their age and their gender. Also, they can be greater or equal to 2 standard deviations below the mean for their age and gender. If we don't catch it by the time the kid goes into puberty, we're going to see that they have delayed puberty. They may have a micropenis. Not every micropenis that you may see in a newborn nursery means they have a growth deficiency, but this is part of the constellation of symptoms that can occur with growth hormone problems. They also have an increased sensitivity to insulin and have a tendency to develop hypoglycemia. The clinical evaluation begins with accurate height and weight. They have to stand with their back against the wall on a heavy wooden measuring stick, and then you use another wooden plate and you put it on the very top of their head. They need to be weighed without their shoes on, heels up against the wall. Labs will include some insulin growth factors. They'll do thyroid function tests, that's what TFT stands for, just to rule out that they don't have a thyroid problem. A CBC that's going to just look to see if they have another issue. And they may do chromosomal analysis to make sure that they actually are gender specific in case there's a question. If anything is abnormal, they will do a growth hormone stimulation test. And this requires several blood tests that has to be done over certain periods of time during the day. The prep for it is to be NPO after midnight, so that would be your patient education. We can also do a bone age, and what they look at is to see where the development of the epiphyseal plate is. Believe it or not, there is a book for radiology that has what the bone age should be throughout childhood, month by month. Further evaluation can include a CT, MRI of the brain, as well as skull films. And these are all looking to see if there's a pituitary tumor or other pituitary issues. Treatment of growth hormone deficiency really improves the quality of life for these kids. They've been picked on the majority of their life because they're so small. They're expecting to go through puberty like their peers, and they're not. And so this is always fodder for bullying. So what we do is give them purified polypeptide hormone of recombinant DNA growth hormone. Many companies make it, and somatropin is one example. Depending on which form they take, they're either getting a sub-Q injection once a week, several times a week, or daily. And we give them this injection until the epiphysis is fully closed. The side effects of the injection can include headache, nausea, vomiting, fatigue, muscle pain, as well as weakness. The nursing education to the parents and child need to include why this medication is needed. And the purpose is it's going to promote bone development. They have to be taught how to drop the medication and how to administer it. And they also need to be given appointments for follow-up with a specialist for height and weight checks. And this ends the Metabolic Disorders series of lectures. Thank you for listening.